Hello everyone, thank you for giving me the opportunity to speak to you today. My name is Selim, a Registrar of Trauma and Orthopedics in Homerton University Hospital, and this presentation is about displaced intra-articular calcaneal fractures. Is there a current consensus for management? Starting with a brief introduction, calcaneal fractures are one of the challenging injuries in orthopedic practice, and the mechanism of injury is usually an axial compressive force, such as falling from height or road traffic accident. The most widely accepted classification system for that is Sanders classification, which depends mainly on the number of the articular fragments on the coronal CT scan. Our focus in this meta-analysis is the displaced intra-articular calcaneal fractures, which involve group 2, 3, and 4. And the main problem here is that management of displaced intra-articular calcaneal fracture has been controversial in literature, with many studies favoring each of the treatment options. So the purpose of this meta-analysis is to provide high-quality recommendations for the management of these injuries based on the best available evidence. As for the methods, we used Medline and Embase databases along with Cochrane library, and the search was done from inception till July 2021. We used the following mesh term: intra-articular fracture, and calcaneus, and displaced, and conservative or surgical management. Our inclusion criteria involved studies directly comparing non-surgical and surgical management, level 1 and 2, which are the RCTs and prospective trials, English language only, and human studies. We excluded studies involving cadavers, biomechanical studies, abstract conference papers, and retrospective studies. This is Prisma flowchart for our research. Records identified in the beginning were 491, and the studies included in the meta-analysis were 13. Then data from eligible studies were retrieved by 2 authors independently. We used the Revman software for interpretation of the data, and in cases with high heterogeneity, I-square more than 75%, a random effect model was applied. This table shows characteristics of the involved studies, starting from 1993 to 2021. 10 were RCTs and 3 prospective studies. 3 were done in the UK. Total number of cases was 1,251. And most of the injuries happened in the middle age group, with more prevalence in males rather than females. The follow-up time ranged from 1 year up to 15 years, and the most commonly used classification system was Sanders. Quality assessment was done using the Cochrane tool for randomized controlled trials and the Newcastle-Ottawa score for the prospective studies. Only good quality studies were included in this analysis, and these figures show the quality assessment for the involved RCTs. As for the results, starting with footwear problem, they were less in patient treated surgically. Return to the pre-injury work or activity also favored the surgical treatment. AOFAS score is slightly favoring the surgical treatment. However, this is not statistically significant because this is still touching the middle line. There is no difference in the residual pain between both groups. Complications in the form of skin problems or nerve injury didn't favor each of the treatment options. Also, there was no difference in the development of arthritis between both groups. So, as per the current analysis, surgical treatment may be superior to the conservative management of these injuries only in certain occasions. Footwear problems are overall lower in patients treated with surgery, and most of the patients treated surgically returned to their pre-injury work or activity. AOFAS score, despite slightly favoring the surgical management, this difference wasn't statistically significant. In terms of residual pain, complications, and development of arthritis, there was no statistically significant difference between both treatment options. Factors suggested in literature to be associated with good outcomes if treated surgically are fractures with fibular impingement, large polar angle, women, young age, and patients not receiving workers' compensation. On the other hand, factors suggested to be associated with bad outcomes if treated surgically are fractures resulting from high energy mechanism, comminution, small polar angle, patients with pre-injury heavy workload, workers' compensation, smoking, alcoholism, and high BMI. We also appreciate that there are some limitations to our research. First of all, the fracture patterns, degree of varus malalignment, and fibular impingement were not specifically compared across the studies, which may affect the outcomes. The follow-up times were as low as 1 year in some studies and up to 15 in others, making the comparison between the functional outcomes challenging. And certain outcomes were not consistently compared across the studies, such as the change in the polar angle, reoperation rates, and life quality scores. In conclusion, surgical treatment of these injuries should be reserved for selected cases with certain fracture pattern and social aspects. Further RCTs comparing specific subgroups of intra-articular calcaneal fractures are needed to draw robust conclusions. Thank you.